just to follow up quickly on the question, the solution proposed by Yasemin is exactly the right one. Is what we looked at yesterday also, and we called it stratification or adjustment. You separate the smoker and non-smoker, and then you compare the effect of drinking coffee within the two groups. So you compare smoker drinking coffee with smoker non-drinking coffee, and non-smoker drinking with non-smoker non-drinking. You calculate the two ratios, and then you pull them up at the end. And you can do this for many, many strata. The effect of smoke, the association of smoke with cancer was initially non-seen in a cohort study. Actually, it looks like smoking was protecting from cancer. And the reason was that mostly young individuals were smoking cigarettes, and old individuals were smoking pipes and cigars, which are less associated with cancer. So and since cancer is associated with age, if you look at the entire cohort, you don't see any effect. It actually looked that smokers are protected because on average they are younger. As soon as you start cutting the population in bands, you can do 2 bands and then 1 bands per age and so on, then the effect appears. So that's the way you deal with confounding, to a point. One tricky consideration, and then I move to my talk, is to be able to stratify, you have to have, in this case, coffee drinkers in both groups. If all those drinking coffee smoke, and all those non-drinking coffee don't smoke, you have no way of stratifying. You can't separate, because you can't look at the effect within the class, and you have no way of adjusting. So stratification and adjustment may work, provided there is overlap in the distribution of the two factors, the one you are interested in and the one you consider a confounder. I have a question for you. Would you consider coffee a confounding factor when you study smoke effect? Or not? Yes, it's absolutely dependent on what your objective is. There is no one that is a confounder by profession. You are a confounder in a specific setting where the investigator has one specific goal, and your role as smoke is being a confounder. If the investigator is interested in you, the smoke, then coffee becomes the confounder. Okay, good. No, sorry, that was the wrong one. This one. Okay, I don't think you need me to introduce myself again, but I have slides to tell you something more. We'll continue going back to what we have learned yesterday and moving one step forward. This is exactly what Yasemin has helped us doing in a brilliant way, and very kindly, and helping us getting up awake again. She touched upon most of the relevant content we had learned or refreshed yesterday. We'll continue. We'll mostly stay on clinical trials and systematic reviews, and some on observational trials, and we will mostly look at what can go wrong and what are points we need to be careful about when reading or considering a piece of literature, a trial or a systematic review, or anyways a piece of evidence. So I will go through a set of cases showing you how relevant can be looking at conflict of interest, choices of comparators, choices of endpoints, both when they are surrogate or composite. Do you know what a surrogate endpoint is? Show of hands. Who knows what a surrogate endpoint is? Well, at least in one of the group yesterday, we spent 5 minutes. Who was in the treatment group with me yesterday? You. Good. So we touched upon surrogate and hard. Who knows what a composite endpoint is? Okay. Good. So you will learn something. Risk of stopping trial early, and again, more on confounding. Confounding is extremely important, so I'm very happy to hear that the question was about how to deal with confounding. This is my research unit, and you see here, well, that's me, that's Brian Haynes. You saw a photo yesterday, and these are all the readers, indexer, we have librarians, we have statisticians, IT people back here. And you have seen the pyramid of evidence. Yasemin showed you this morning. I think I had a slide yesterday. Brian Haynes was the one having the idea of the pyramid of evidence. And one of the things I like of being at McMaster is that it happened to you to have coffee or work with people who created almost everything of evidence-based medicine, for the good or the bad. But whatever you can name in the field of EBM, one way or another has been created or improved and disseminated through activity at McMaster. And we try to continue this tradition at the Health Information Research Unit. That's the website, and that's where you can get a lot of information about what we do and how do we appraise literature. So let's move to conflict of interest. Can anyone give me a definition of conflict of interest? What is a conflict of interest? You can think even beyond published literature. What's a conflict of interest in life? Okay, so the colleague proposes a case where a study is funded by a drug company, and the drug company, of course, wants the drug to succeed and being shown to be effective. That's a good example. Anyone can think of a different example.
Is it like bias?
The question is a question to me is, can a conflict of interest be thought of as bias? Yes, they can create bias. What is bias then? Bias is a deviation toward one specific direction. So in this case, in the example proposed by the colleague, they will try to underplay cases that go against the efficacy of the drug. Failures in the treatment group will be forgotten about, and instead failures in the placebo group will be absolutely counted to the last one. Any suggestion of another conflict of interest? Another category or another type? Is only pharma? If I'm building my career on a test used to diagnose DVT, and I'm doing a study where I try to show that the test works, do you think I have a conflict? Yes. Or even if I'm not doing trial, if I built my career by going around speaking of thrombophilia in pregnancy, do you think in doing a systematic review on thrombophilia role in pregnancy, I can have a bias? Could that be a conflict? Yes. So conflict of interest is any situation where the individual doing the research, participating in the research if he's a patient, assessing outcome, or any role in research can have an interest in the study going one direction more than the other. That's the conflict of interest. Is something different from willing to know what the truth is. And it's not necessarily something that is obvious or bad. I may understand that pharma try to make trial for good drugs. First of all, they try to make good drugs, ideally, and they try to show where they work. Then you may think of bias that is intentional, malicious. But even if it's not malicious, it's just what they do. And the same is for the investigator or the expert. Now, there was an experiment done a few years back, now 10 years back, where this group of authors from the Danish Cochrane Center, they picked at random 25 Cochrane reviews out of about 300 published that year. And those 25 Cochrane reviews were including about 1,000 studies. And they randomly selected 100 of those studies. And they then excluded some studies that had risk of bias characteristics that were showing those studies as not good. And they ended with a subset of good studies included in a random sample of good studies in a random sample of Cochrane reviews. And they abstracted information about funding. And they classified the result of the study by using a scale 1 to 6, where 1 was the conclusion showed that the control was better, so placebo was really winning over the drug, which means the drug was not doing good, was actually doing harm, or the comparator was doing better than the drug. So you would imagine that if you choose a control, you hope to have something better to give people. Why you do a trial in the first place? You do a trial because you are unsure if the new treatment is better than the existing one. You are unsure if a drug does better than placebo. You have to have equipoise. If you know what's better, no point for a trial. You just do what's better. But if you don't know, you do the trial. Of course, your hope is that the new treatment, what you are proposing, is better, because that's behind research. There is equipoise, you don't know, but you hope to improve. So you would expect that you have to be really tough to say, okay, I tried, I spent millions, I enrolled 3,000 patients, spent 2 years of my life to show that, unfortunately, my idea was wrong and the medication, the intervention doesn't work. 6 is the experimental control, the experimental treatment does really well, strong recommendation in favor. Now, if you look at the result, you see that there is a clear trend here for the proportion of trial that get a higher score with involvement of funding organization. So non-for-profit high, and then we don't know, some profit and non-for-profit and for-profit. So pharma, among the sponsor, a growing number of trials and growing number of trials having conclusion in the direction of the intervention work. How can you interpret data like this? What do you think? You don't know. Well, correct, and the author went in without an hypothesis. So they looked for predictor of larger effect size. Predictors, of positive result. Their outcome was that scale 1 to 6. Result presented as positive for the treatment. So the bigger the effect size, the more likely the conclusion where this treatment works, use it. So if the risk reduction was 20, 50, or 70, the higher the risk reduction, the higher the chance for the paper to tell this is a good treatment, use it. Do you find this wrong? Anyone find this right? Well, I think it's right. If the treatment is more effective, you are more convinced to recommend it. Blinding. If the study was blinded, the recommendation was stronger. Do you think this is wrong or right? Right. Someone said wrong? No, right. Because this is a quality characteristics of the study. But now also having a for-profit funder was associated with a stronger recommendation. Is this right or wrong? Wrong. You may be right, but how can you tell just by looking at this one? So there were 3 factors associated with stronger recommendation, and for 2 of them you have said right, and for 1 you say wrong. Well, can't yourself be biased? Well, it might well be that everyone says, oh, pharma does wrong trial. So how can you try to answer the question? Any suggestion? No. Well, one suggestion is to look at all the 3 together, see how they distribute among the studies. And one may conclude that published studies, no matter how large the effect size is, if there is a funder involved, if they are blinded or not, just because they are published, they are good evidence to be used. Then one might say, well, okay, but for profit, they show larger effect. Why? Well, one reason is that pharma has a lot of money. And you know, doing a randomized, placebo-controlled, double dummy study costs millions and millions. And you may say, well, for sure, the large effect in blinded studies is associated with pharma sponsoring. There's no other way of doing trials. So that's the reason it's associated. It's not because they are bad, it's just because you need money to do trials. Or the opposite. No, the reason is they massage the data, they change things to show that their molecule works. Or you can even be more extreme and say, oh, the literature is full of sponsored study, I don't believe sponsored study, and published literature is no good. And Yasemin was saying we all like New England. Well, you would be surprised, but the proportion of sponsored study is highest on New England than in any other journal. And New England lives out of advertising. 30% of their income come from pharma-sponsored study. They sell reprint. And pharma, when there is a study that is positive, good or bad that the study is, they buy thousands and thousands, millions of reprints, and they distribute to us when we are wearing our clinical hat. So, is accepting money from pharma a bias for a journal? Well, depends. It may well be. And there is another systematic review showing how likely it is for a negative study to be published in New England and in non-sponsored journal, and is much higher in non-sponsored journal. New England doesn't like negative studies. Okay. Now, there's a solution, because we are still there. We are still at saying, well, for profit can be associated because they do better studies, or they bias the interpretation, and maybe we can believe the literature, maybe we cannot. Again, the solution is stratification. You take large effect, high quality study, and you compare for profit. Small effect, high quality, you compare for profit against others, and so on. You create all the strata. Stratification helps us in many, many cases. When you don't understand a complex picture, you try to understand the small pieces first, and then to put the puzzle together. That's a common approach in appraisal of study. So if we do this stratification, then we can tell that if you assume that as a comparator, non-profit studies, after we have adjusted, you'll see that the odd ratio increases after adjusting from non-profit to for-profit 5 times more likely to show positive result. And this is after having adjusted for large effect, small effect, high quality, low quality. So the association between funding and positive result, strong recommendation, is non-dependent on how big the study is, how well done the study is. It's not the money you put into the study. If the treatment effect is negative, it's very difficult to have a strong conclusion, which means bias is not all in funding. When the treatment doesn't work, we are a bit lukewarm in saying the result, independently from funding. That's a conflict for all kind of investigator. Double blinding increases the chance of strong conclusion. So what's the take-home message here? Is to read the method and result, yes, so you know which kind of study is, but also check the funding source and check the conflict of interest, considering the economical one, but also the intellectual one that the author can have. And skip the discussion. The discussion is the part where, even if the results are negative, you try to say, yes, are negative, but. That but is the place where the conflict of interest play a lot of role. And you try to say, yes, it doesn't work in general, but it works in this small subgroup. That was not pre-planned. You should be honest and say, I tried every kind of subgroup until I found one that worked by chance. You know, every 20 studies, one is positive, one is different. Every 20 subgroups, one is significant by chance. But sometimes for pharma, that's important, because you get one subgroup where by chance the drug works, you get approval, and then is where the bias acts. Then you go doctor by doctor saying, you know, this drug is approved only for these teeth here, not for every teeth in the mouth, only the left upper canine, but you know, it's available, it's here, why don't you use it for the others? And I mean, I don't need to tell you how that works. But that's the way it does. You select a small group, and then you expand later on to everything. Comments or questions on conflict of interest? Good. So let's move to wrong comparators. Can't say this is funny, but it's nicer than conflict of interest. So the most common mistake, or the most common flow in a clinical trial is choosing a placebo comparator when there is a active treatment. Now, you may be clever in suggesting one case where even if there is a standard of care, you may use a placebo. We'll come back to that in a second, but let's first take the most common point. Is anyone here a diabetologist? Any one of you treat diabetes? Even if you are not a diabetologist, do you see patients with diabetes? Okay, so can you tell me any medication that you would use without doubt in patients with with diabetes-associated kidney impairment? ACE inhibitors. So you don't need to go to search the literature. You know. Everyone knows. If you don't know, you have a problem. ACE inhibitors, they help diabetics with kidney impairment. Now, at some point, you know what's the most common side effect for ACE inhibitors? Cough, right. So, at some point, since the drug was very, very useful in this class of patients, but was causing cough, research came up with ARB, angiotensin receptor blockers. And they do not give cough, or much less cough. So they can be used in those patients. But of course, you know, why using them only in the small proportion of patients having cough? Why don't we try to use them for everyone? Now, if you were to show the efficacy of ARB for diabetic nephropathy, what would you choose as a comparator? ACE, right? It's clear. Instead, all the studies that were published were against placebo. Why do you think that is? Just to show an effect. Can't you show an effect against ACE? Okay, so the colleague here is suggesting that you may not be able to show an effect, because to show an effect, the ARB should be more effective than ACE. And of course, that might be, first of all, not the case. Second, it might require a ton of patients. Are you aware of any study design that you can use when your objective is not saying this is better, but is saying this is equal? Non-inferiority. So you may say, I'm happy with what ACE do. I want to show that this molecule is non-inferior. And you set a threshold for non-inferiority, you do a very large trial, and then your point would be saying, okay, these are non-inferior and they do not give CAF. Fine, there's only one problem. It's very difficult to have a higher price with a non-inferior drug. Usually you get the same price, and that's not very appealing to industry. So one reason is this one. Any other reason you can imagine not to use an active comparator? It's a bit more tricky. It's called regression toward the mean. So when you say that ACE inhibitor is better than placebo, there is some difference. But you know that that difference can be bigger in some population, smaller in other. There might even be population where ACE inhibitor do not work. Blacks, for example, black people. Now, if you compare the new molecule against the active, and you get the active in a point where it doesn't work, you may show that a non-effective drug is still better than that one. This is called regression toward the mean. If you are unlucky and the effect in your study of the active drug is less than it would, then you may show efficacy for a drug that is not effective. And that's the reason why FDA wants, for example, at least one placebo-controlled trial. As the colleague was suggesting, to show efficacy. After you show that it works against placebo, then you go to to study against an active comparator. Okay, so you have convinced me there are good reasons to do placebo-controlled trials. But in life, to choose between one of these two, do you need placebo-controlled trials or you need active controlled trials? Active controlled trials. So why no one was done here? Well, possibly because, again, there was some interest or some policy willing to say, or some maybe data in the animal, saying it's not good to go to the direct comparison. We won't win against the ACE inhibitor. Now, I told you yesterday that you can do network meta-analysis. I just dropped 2 slides. So what you can do is saying, okay, let's look at all the studies. We have a placebo, the most commonly used drug in any indication, and then you have ACE inhibitors, a lot of studies, 10 studies comparing these two. And then you have the ARB, and you have 5 studies comparing the ARB against placebo. So you have 10 plus 15, 15 arms of placebo, 10 arms of ACE inhibitor, 5 arms of ARB. You also have 3 studies doing a direct comparison. And this is for mortality. But if you look at another outcome, end-stage kidney disease, this is what we are interested in now, right? Effect on kidney. You still have a lot of placebo, 4 plus 3, 7 arms of placebo, 4 arms of ACE inhibitor, 2 arms of ARB, and a direct comparison here. And then you can also learn something, for example, by ACE inhibitor plus ARB versus ARB, or versus ACE inhibitor, and so on. Every connection in the network can help you deciding. The most common display and the most useful display of this network meta-analysis is a plot like this. In this case, this is all-cause mortality, usual forest plot. So this side, active drug better, this side, comparator better. So less death with the treatment, more death with the treatment. And you see all the possible combination compared one with the other. And here you can pick, because if you want to maximize the reduction in mortality, ACE inhibitor plus calcium channel blocker. Here, strong effect and is significant. Or ACE inhibitor plus ARB, smaller effect, still significant. And for example, ACE inhibitor, it's here. Yes, there is a likely effect, but it's not significant. Where is ARB alone? ARB is here, so it may be better than ACE inhibitor, not very different, but maybe better, and so on. Endothelin inhibitor doesn't look that good. Beta blocker, they kill people. Okay? Now, you move to end-stage renal disease, and it's the same. You have here the ARB, in this case, ACE inhibitor, more uncertainty, but possibly also bigger effect. Combination for sure is better and certainly effective. This was not possible to imagine before studying them, because they act on the same mechanism. Why expect that they do better together? And then the physiologists among you, they know why you have some extra effect by combining them. But was shown initially in clinic, and then they went back and they found the reason, and so on. This class of inhibitors, they don't work. Now, you can continue. Acute kidney injury, doubling of serum creatinine. You may want not to wait until the patient is in renal insufficiency. You want to monitor creatinine with time. The effect on creatinine for ARB and ACE inhibitor is more or less the same. Calcium channel alone, they don't do really well. But if you recall, they actually help a lot with mortality when they are associated. But their effect on creatinine, is not ideal. Now, keep in mind the effect of endothelin inhibitor here. This seems to be the best to slow down the improvement of creatinine. Was not really brilliant on mortality and end-stage kidney disease, but works well on creatinine. And if you look at albuminuria, that's another way of assessing the effect on kidney disease, right? The diabetic kidney loses protein. And these drugs are so powerful in protecting the kidney that you may have regression of the amount of protein you lose. And more regression with placebo on this side, so this time the good is on the right. And you see that depending on the class, you have a nice effect that is best with, again, ARB and calcium channel, and then is minimum with diuretics. So you learn a lot by comparing active treatment, and you learn what you need to decide what to give to a patient. So in this case, you may pick the best effect for the outcome you want to obtain, and you have a fair comparison among all treatment. The problem with comparators can be more complicated. For example, if you look at these 8 trials comparing second-generation neuroleptics against 20 milligram of haloperidol, a first-generation neuroleptic, you would see that they give less extrapyramidal symptoms. So why not to use them? Any suggestion why not to use them? Any neurologist here or psychiatrist? I'm sure there is a neurologist in here, or a psychiatrist. Well, first of all, someone would ask, are they equally effective? Because before looking at they are better tolerated, would be important to know if they are equally effective, right? So you can't decide based on this. And this, you do not need to be neurologist or psychiatrist to ask. But something that is trickier is, well, we are speaking of comparators, so what can be wrong with the comparator here? Dose, right. The standard dose of haloperidol is lower than that. So I'm not really happy or able to use this information, because those, if I go up to 20, I almost always get side effect with haloperidol. So what's the point? What I need to know is, do they give less effect at the proper dose? So wrong dose. Or in this case, paroxetine compared with amitriptyline twice a day showed to give less somnolence. What's wrong here? You give it once a day. So you usually take amitriptyline before coming to a course, right? So it's painless for you. You sleep all day and you don't get bored by the speaker. No, you give amitriptyline at bedtime because you get the antidepressant effect and you also help the poor guy sleeping. And depression is sometimes, very often, associated with the sleep disturbances. So you are drowsy during the day, but you don't sleep at night. So it's actually good that amitriptyline help you sleeping if you give it properly. So why the study choose to have amitriptyline twice a day? Well, just to try to show that paroxetine was better. This is how you can put bias into trials. And these are the references. If you get the slides and you are curious or you want to know if I misread the trial, those are the references. So beware of the comparator. To make a judgment when a trial claims for efficacy of a treatment, always look, is the comparator something I will be using? Or is placebo something I'm happy to hear about as the comparator in this trial? Surrogate endpoint. So, who dare giving a definition of surrogate? You know what a surrogate is for coffee. What can you use instead of coffee? Tea. Well, tea is very good. It's not a surrogate. It's a drinking on its own. But I don't know here in Kuwait, maybe you never had that problem. In Italy, back in the World War II, there was no coffee anymore brought to the country. We can't raise coffee in Italy. It's not enough dry. And they were brewing everything to try to get some black beverage. And they were eating, brewing salad. You are laughing, but during the war, you do everything. And they were drying up salad leaves, and then they were brewing them. And well, it's not particularly good, but you may know oat. You can do coffee with oat. There is no caffeine in it. It's good for kids. It's black. It's not particularly distasteful. It doesn't help you if you are craving for caffeine. So that's a surrogate. If you look at the list of surrogate for chocolate, you can do chocolate with everything. Not to say wine, you can do wine with everything. Or mozzarella in Italy. You can do mozzarella with everything, but not milk, and not cow milk. So surrogate is the same. It's not your main outcome. Your main outcome is survival. Your main outcome is stroke. Kidney. Kidney function is your main outcome. What can be a surrogate for kidney function? Creatinine level. Now, what is a good surrogate and a bad surrogate? I don't like coffee done with salad. But I might like decaffeinated coffee. You can call it a surrogate. So what's the characteristics that a surrogate has to have to work? It has to be related to the outcome. So is creatinine clearance related to the outcome, progression to end-stage renal disease? Yes. So it is, but the association to be good has to be linear and univoc. Everyone, if I ask you, do you think that everyone with end-stage renal disease has increased creatinine? What's your answer? Yes. If you find one with end-stage renal disease, normal creatinine, there is something wrong. It may indeed happen. You may have a wrong way of calculating creatinine clearance. It might be particularly lean, or you may have a mistake related to the body composition. But usually, end-stage renal disease, you have high creatinine, 99% of cases. Is the opposite true? Everyone with high creatinine have renal insufficiency? No. Everyone with high creatinine will end in having renal insufficiency? No. So, is a good surrogate then? The nephrologist among us down there is sort of saying, it's better than nothing, right? So if the drug has no effect on creatinine, it's very unlikely for that treatment to impact on renal insufficiency. If the treatment is not slowing down the increase of creatinine, very unlikely for it to prevent renal insufficiency. But if the drug slow down creatinine increase, still may not prevent from renal insufficiency, because the link is there, but is not automatic. So if I were to tell you, patient on warfarin, if they have irregular INR, do they bleed more? Yes, they do. We know that if the patient doesn't stay in the range, the chance of bleeding is higher. He will not bleed every single time he's above the range, but if he spends more time above the range, he is more likely to bleed. So since the association is very direct and very robust, I can use the surrogate endpoint INR level instead than doing a study measuring bleeds. But for creatinine, here I have a strong effect, and we have shown before that this does not correlate with protection against kidney disease. And the same is for albuminuria. So surrogate outcome may not be always good. I'll give you another example, still remaining in diabetes. At some point on Lancet, a good journal, 5,000 patients, where a study was published showing that 5,000 patients randomized to just lifestyle or lifestyle plus rosiglitazone had a different outcome in terms of diabetes. This trial was trying to answer the question, can we prevent diabetes by giving an anti-diabetic to patients with abnormal tolerance tests before they fit criteria for diabetes? 3-5 years of follow-up. And these were the study results. So composite primary outcome, we'll come back to the composite primary outcome, but for now take it at face value. Those treated had much less diagnosis of diabetes, much less composite outcome than placebo. 11% against 26, so 15% less composite outcome, and the components were all reduced. So diabetes, 25% in the placebo, 10% in rosiglitazone. Diagnosed done by oral tolerance test, less, 8 against 21. Clinical diagnosis, 2% against 4. Death, 1% against 1.3. No difference in death, but many less diagnoses of diabetes. Are you convinced by this data? Why not? I mean, it doesn't impact mortality, okay, but in terms of diabetes, those taking rosiglitazone, 15% less in 5 years were diagnosed with diabetes, and about 12% less using an objective test, 2% less using clinical diagnosis. So less incidence of diabetes. And if we look at the cardiovascular outcomes, actually there were a few more. So maybe this medication protects you from diabetes, but has some cardiovascular risk. This would not be new. But in general, very similar, no statistical difference. The only one that worries us a bit is heart failure. So there is a 5-time increase, very low number, 2 here, 14 here, out of 5,000 patients, so very, very little, but still, 2 and 14 is a 7-time increase in cardiac heart failure. Now, what the author conclude? They say that in high-risk patients, those with glucose intolerance, 8 milligrams per day of rosiglitazone plus lifestyle intervention reduced diabetes by 60% relative or 14% absolute. So every 7 patients you treat in 3 years, you save 1 case of diabetes. And if you treat 1,000 patients for 3 years, you prevent 144 cases of diabetes. You also induce 5 cases of CHF, but you prevent 144 cases of diabetes. And the price to pay is 5 patients, they get CHF. They are not happy, but the other 141 are. Yeah, side effects are unavoidable. It's a matter of balancing them. Now, what's the author message? Well, they want to use rosiglitazone, and they say everyone should get rosiglitazone, and those with risk factor for cardiac disease, they might not, or not indicated. What do you think they concluded? Strong indication for all? Use it, but only for some, or do not use it? What do you think the conclusion of the paper were? Strong for everyone. Do you use it in your practice? No. And why not? Sorry? Can you tell it louder? Was withdrawn? Yes, okay. So you can't. But if it was available, would you use it? Why was withdrawn? Yes. So let's assume there was no side effect. Would you use it? No. And the reason is the one I'm trying to tell you now. So you imagine a patient coming to you saying, what I gain by, he has a positive test, and he asks you, what I gain by taking rosiglitazone? And your answer is, well, you reduce your chance of getting diabetes. And then the patient is a patient, he's not a doctor, so he tells you, well, what happens if I get diabetes? Well, you have to take a drug. Fine, but again, I'm not a doctor. Which drug? Will you give me the same drug you give me to prevent diabetes? And the doctor says, well, no, I could give you a better one with less side effects. And so, really, if you think of it, why should I take a drug for 3 years to avoid having a disease that is not killing me, because you are telling me that the only thing that happened to me if I have diabetes, I have to take a medication. And the medication you would give me if I get diabetes is less problematic than the one you want to give me to prevent diabetes. Why should I take this medication? And indeed, there is no reason. And was a surrogate endpoint. The diagnosis of diabetes is not diabetes. And even diabetes is not the end objective. The objective is survival, quality of life, is not having renal insufficiency, end-stage renal failure, and retinopathy, and so on. This topic was also reviewed by Victor Montori, one of the brightest fellow that attended the McMaster Health Research Methodology course, and he co-authored this paper with Gord Guyot and others, and they went back looking at the side effects, and indeed they found a significant increase in myocardial infarction, stroke, cardiovascular death, heart failure, peripheral edema, and so on. And this is why then the medication was withdrawn. So not indicated. And even if was not having bad effects, this choice of the outcome was not the right one. There are hundreds of problematic surrogate outcomes. For example, if you have Alzheimer's, the goal is not improving your cognitive function. There's no hope. That will decline. The goal of treatment if you speak with a caregiver of patient, is improving function and behavior, is keeping this patient calm enough to continue enjoy for what they can their life and have their family relatives and caregivers to enjoy life. So all trials showing improvement in cognitive function are questionable. Bone density instead of fracture. You can show that biphosphonates, any new biphosphonate increases bone density, but then it's not automatic that increased bone density will prevent fractures. You may have denser bone that is disrupted in the structure and is more fragile than the weak natural bone. So you need to show that the surrogate correlate well with the heart. Oxygen level instead of mortality. In ARDS, you can give as much oxygen as you want. You can kill a person giving too much oxygen. But if your outcome is how much oxygen I get in the blood, well, you get better. Patient is not anymore alive, though. Asymptomatic DVT instead of symptomatic. You saw yesterday the case of the travel and these isolated asymptomatic calf clot. Do they mean anything? Or they just dissolve as soon as you walk out of the plane and you run to catch the bus, or particularly the connection. Maybe you run enough that you solve the clot. So no clear association. Pulmonary function test instead that clinical exacerbation of COPD and so on. Lipids instead of cardiovascular events. Lipids are correlated, but are very low level correlated as compared to moderately low level? We don't know. So surrogate endpoints, you can use them. You can use trial reporting them. Beware if they make sense. Do not treat symptoms. I don't know how it's in medical school here in Kuwait. There are symptoms you want to treat, pain. All those symptoms that affect life and function and, quality of life and function mostly. You treat the symptom. The symptom is as important as the underlying disease. You treat symptoms in cancer in the palliative phase. But whenever you can treat the underlying mechanism, the symptom will solve automatically. So treat symptoms only if you have nothing better. Use surrogate only if you have nothing better. And maybe the nothing better is we can't for each new antihypertensive when we try to avoid side effects to go for mortality. We know that high blood pressure is correlated to cerebral hemorrhage, renal disease, and mortality. We can't do mega trial anytime, but we know already of the association. If the association is not there, beware of surrogate endpoint. Any comment on surrogate endpoint? Good. So let's move on. We have 3 more to go. Sorry, I forgot the composite endpoint because it was partly already appearing here. So composite endpoint is when you pull together different endpoints in a single number. Why you want to do so? Good reason to use combined composite endpoint. Anyone has a good reason? Increase the statistical power. So you get myocardial infarction, stroke, and peripheral arterial disease as outcome of atherosclerosis. And you say, I don't really matter if I'm preventing a myocardial infarction, a stroke, or a leg amputation. They are all good things to prevent. I just pile them up because I have more and I get more statistical power. Another good reason to combine? Increase? Yes. Decrease the sample size. And also, would you be happy with a medication that prevents myocardial infarction but increases stroke? No. I mean, if you are a cardiologist, you may say, well, you know, stroke someone else look after, so from my perspective it's good. But in general, you want to prevent mortality. You want to increase survival. So you want to avoid myocardial infarction and stroke. Now, if you have no medication that does so, well, you can say, I use two treatments, one to prevent myocardial infarction and one to prevent stroke, and I might even accept a medication that produces a slight increase in stroke if I have a way of counteracting that effect. So one reason to consider composite endpoint is to be sure that the balance is in favor or against. So there are outcomes that can be combined, like stroke, myocardial infarction, and peripheral arterial disease. Do you know how this is called? This is a very common composite endpoint. Cardiovascular morbidity or cardiovascular accident. It covers these three categories. Can you name other composite endpoint commonly used, for example, in cardiology? MACE is the combination of all the coronary syndromes. Doesn't really matter if you reduce NSTEMI or STEMI, or altogether is good to reduce. So you have categories that are created because that's what you want to prevent. So they are not bad in general. But look at this example. Again, irbesartan versus amlodipine in diabetic nephropathy. And they tell you that the new molecule reduces a composite done of all-cause mortality, progression to end-stage renal disease, and a doubling of serum creatinine. And the relative risk reduction was 20%. Is this a good composite? Or not? What do you think? I need someone to take a position. Is good or not? Sorry? The confidence interval is, is wide, but it's still good. Wouldn't you go for a treatment that has a 7% reduction in the combination of those three? 7% per year, maybe. This was a year treatment. Is not bad. So the confidence, and it can be as high as 30%. So if you are optimistic, you look at the higher end of the confidence interval. It's not ideal, but it's good. No, the problem is not the confidence interval. What's the problem with this composite? I'll try to help you. Oh, please. The last endpoint is surrogate. Right. So can you tell that the treatment reduces mortality? No. So the composite would be good if you would be okay if getting an improvement only in creatinine. And let's see how the numbers were. So the composite endpoint is in favor, 20% reduction, and these are the confidence interval that your colleague was not happy with. They are not ideal. I mean, it's wide, but it's far enough from the identity line that you get some benefit. Then it depends how much it costs, side effects, and so on. But overall, the composite is good. Now, the doubling of creatinine is brilliant, right? 30% or, 33%. And end-stage renal disease, still good. I mean, may not be significant, but very, very marginally. In general, there's a high chance that you are preventing end-stage renal disease. What about mortality? Well, it actually increases mortality a bit. It's not sure. There can still be a gain, but there can also be a huge detriment in terms of mortality. So the problem with this endpoint is that it combines surrogate and hard, and you can't judge on the composite until you see the components. So the basic rule for you is if you see a trial where there is a composite and they don't tell you the ingredients, it's like if it happened to you to be in Germany and you eat sausages, and you don't know what they do the sausages, what they put in the sausages. You don't eat if you don't know what's in. They all look the same, but they can be done with everything. And was Bismarck saying, never tell people what we use to make to do sausages and the decision we make when it comes to war. Better not to know. So what has gone wrong? The different importance. And also that in this specific case, the biggest effect was on the least important one. And the most important one had no effect. So the basic rule is to always use criteria for composite endpoint where you choose endpoints that are similar in importance and go in similar direction. You don't want to combine ischemic stroke and hemorrhagic stroke. I mean, you can if you want to measure the overall effect, but if you want to assess the efficacy as an anticoagulant, you consider the hemorrhagic stroke as a side effect, and you don't put it in the composite effect. So again, whenever there are composite endpoints, whenever you eat sausages, look for the ingredients. And eat something else, usually. Okay. So, trial stopped early. Is it good to stop early a trial? Sometimes. When?
If there's obvious harm.
If there is obvious harm. So, you see, the trial is randomized and double-blind. How can you tell that there is obvious harm?
Maybe there's high mortality.
High mortality in one group. You don't know which group, but there is high mortality. And that mortality usually is higher than you would have expected in the control group. So something's wrong. Because the mortality as high as you expect, that's okay. Maybe that's the placebo group. But if it gets higher, you say, oh, something goes wrong here, we are killing people, let's stop. Okay. Any other case where you want to stop early? Obvious benefit. Which is more or less like, is the reverse. Why you stop early in case of obvious benefit? Ethical. So you may want to give that treatment to everyone because now you have discovered the treatment that is effective and you feel is not any more ethical to deny that treatment to the control group. Okay, 1/3 good reason. Cost? Well, of course. I mean, in general, if the trial is not useless, is not useful anymore, if we have the answer, would be a waste of money. But no, there's another reason. Lost at follow-up. So the trial is not working. It's fine. If the trial is not working, patients are not enrolled, but it's not that you stopped early, it's just it fails. It's not that you decide to stop early, just it dies of its own death. Patients do not get into the trial. No, it's another reason. When the trial is going well, is enrolling, but you decide not to continue. So one case, too many deaths, one case, strong effect. What's the other possible case? Come on. No effect, right. After a while, you see that there is no difference between the two groups, and you have enrolled enough patients that you do some math and some projection, and you say, well, even if we get to enroll everyone, there's no more space for a difference. You stop for futility. Would be silly to continue. There's no difference that you will be able to see. Okay, now, futility, everyone agrees. If you see no difference, you stop. Okay. Safety, no one complains. And everyone says, okay, in case of too many deaths, you have to stop. I will make a comment at the end on this, but everyone accepts it. Now, where the problem can be is when it comes to effect. Look at this one. This is a trial, a very long trial comparing 5 versus 4 courses of chemotherapy for AML. And they did analysis over time, And there was of course, initial observation, seems better to continue. Then they start a trial. Initially, there seems to be an effect. Then as you continue, this effect seems to be actually more significant, and then the confidence interval narrows, but the effect is less and less. And if you continue enough, this is just the trial continuing. It was significant in the beginning, and it come to show no difference in the end. Why is that?
Side effects with time.
More side effect with time, for example. You are right, patients stay on and something else happen and the balance is different. But if we had followed the colleague advice, we might have stopped here at, say, 1998, saying, okay, we have done enough, the confidence interval is narrowing, it stays on this side. They continued because it was trending this side, and they did it well. And actually this treatment is killing people on the long term. The problem is that if you consider the no effect line, this is a sleeping forest plot, right? I thought that at this time of the talk, a sleeping forest plot was better because I expected many of you being on the side. So it's the same as a standard forest plot. It just lays down. This is the identity line, and this is the true effect. Now, usually, data go around this way, so you have some variability around the true effect. And this is a standard case where you have small variability. But you may have a case like this, where initially it goes really bad. Now, this is where we have some problem. If this is bad, but not bad enough to cause problem with mortality, so say people is not dying in this trial, they are only having more relapse in AML, but then they can be treated. One, keep on, hold on, and then at some point, this trial that start very badly can go to show an effect. But you can also have the opposite case, where initially it's all extremely well, and then the effect settled to some other level. There can be still an effect, or it can go down and show harm, like in the example of leukemia. Now, if you have a stopping boundary here, you do interim analysis, and you set some rules, and you say, if we see a difference higher than this one, we stop the trial. You can stop this trial in all this point. Say you can stop it here, or here, here. Oops, one too many. You can stop at any of this point, and you can call for a benefit, when indeed the benefit was there, but was less than that, or was even questionable. It might get to show no effect at all. So in stopping early, you accept some risk. And it's not that you do not believe that trial, but usually you can't do anything more with that trial. If they had stopped it, they had stopped it. Usually a terrible consequence is that, say there are 3 concomitant parallel trial testing. Yesterday you saw the addition of clopidogrel early in treatment to prevent stroke. And there are 3 trials, and one is stopped early. Usually all the others are stopped, and there will be no more trial. So we will never know that the effect was much less, or we will know. What do you think? Well, we will never know through a trial, but if we'll do database analysis, we will find out that we were expecting such a benefit, and instead going to look into the Danish cohort database or the Norwegian national database, we don't see that effect. And then you'll go back, you redo the analysis, and you show that the effect was much less. So it's very dangerous stopping a trial early. If it happens, the recommendation is, and this is agreed upon by most clinical epidemiologists, never give a strong recommendation in a guideline based on a trial stopped early. Always wait for a second trial. Unfortunately, sometimes the second trial never happens. Now, my point is that this can happen even with mortality. So even if it's tough to say, no, they are dying more, but it's transient, let's wait, and we will see the same effect with mortality. No one does that, but if you think of it logically, benefit or mortality are just opposite side of a curve. So even when you stop early for mortality, you may deny a treatment that might have proven effective if we had continued doing the trial. Unfortunately, everyone is willing to hold on for effect, but very few are willing to hold on when there is an excess mortality. But the excess mortality can be chance as much as the benefit. Very few clinical epidemiologists dare saying what I'm saying now, but if you look at statistics, if you ask statisticians, they say death is no exception. Can be chance finding as anything else. It's just sad for doctors to observe. And there are also legal implications in continuing a trial when, if it stays up there, then you may have a court of patients that claims damage against you for not having stopped early. If there is lack of benefit, there is no possibility there is no class action for denied benefit, but there is a class action for death. So is a very economical reason why you stop for death. Another beware when trial are stopped early. Now, one final point on confounding. I think we won't possibly take the 20 minutes that are left, so you will still have 10 minutes of stretching. But let's discuss confounding once more with an example coming from McMaster. So there's a very florid research line at McMaster on perioperative medicine. P.J. Devereaux at PHRI, Population Health Research Institute, and he's actually a colleague in CEB, and now we are redesigning most of our methods around perioperative medicine. We have done a lot of research around clots and atrial fibrillation until now, and was mostly Jack Hirsch, Stuart Connolly, Salim Yusuf. That research group was very, very successful in getting money and in getting a lot of randomized trial, and EBM was built in that field. Now we are investing in perioperative medicine. And the reason is that there are hundreds of millions of people undergoing surgery, and there are a lot of complication, cardiovascular complication around surgery. How many of you are surgeons? Good. So surgery is needed, but surgery, as you know, is a hard challenge for patients, and it increases mortality per se. Solve a problem, but expose you to risk of death. Now, one of the mechanisms that happen during surgery is that there is a stress reaction, increased level of catecholamines, and increase in heart rate, blood pressure, and so on, oxygen demand. So there are many physiological mechanisms that can lead to acute coronary syndromes. And beta blockers can slow down the heart, decrease blood pressure. They have a positive effect on free fatty acid, reduce the oxygen demand, and so on. So why not try them? And indeed, since 1999, there was some evidence that beta blockers were producing positive effect on myocardial function, particularly when compared with placebo, and even having primary endpoints, hard endpoints, so not only functional one, there were some suggested benefit. And this was 1999. The first trial was done and was stopped at 100 patients because of benefit. So you now are a bit suspicious because you know about, but back then in 1999, the benefit was there and was striking. So in placebo, 18 patients in 53, 34%, had the primary endpoint. In those treated, only 2 in 59. And the primary endpoint, you now know, was a composite of all of these. So was a composite of function and death and non-fatal myocardial infarction. Now, well, would you have stopped? Sure, is a striking reduction. The relative risk was 0.09, so over 90% reduction. Why not? A few other trials, this was Polderman's, and then there were small initial evidence here, not really so striking, and then other trials, some successful, some not. The combined estimate, anyways, around this systematic review was for a protective effect. And, but you see, there is a lot of heterogeneity. Why so much heterogeneity? And then someone thought, well, maybe the effect is proportionate to the risk. And this paper on New England in 2005 showed very nicely that the effect of the beta blockers was seen only for more severe cases. If you score them, or if you look at the component of the score, you see that there is a linear relationship between the effect and the severity. Still, there was someone that was not convinced. And they said, well, okay, now let's have a final proof by selecting patient in the right risk category. And this is what the POISE study was meant to do, about little short of 10,000 patients randomized to beta blocker or placebo. And the primary outcome, again, a composite of death, non-fatal MI, and non-fatal coronary, was in favor. About 1.1% reduction. Cardiovascular death, non-significant, so no benefit, no harm. Sorry, myocardial infarction, I was looking at the wrong slide on the screen. Myocardial infarction still benefit, 2%, 1 point something percent reduction. Nothing on death. So no better, no worse, more or less the same. Effect for the composite, effect for non-fatal MI, no difference for cardiovascular death. These are the, and no effect for non-fatal. These are the curves. So beta blockers do reduce the risk, both for the composite and non-fatal MI. What about secondary outcomes? And here is where the large trial shows some difference. Total mortality is increased. So the composite outcome was all about cardiovascular, but something happened there, and there was an increase in total mortality. It's always good to count total mortality. It's very difficult to show positive effect on total mortality in a study, but if you show a negative effect, well, there's something wrong there. And was 1%, and was clear on the Kaplan-Meier. So again, every step is an event, and you see the placebo group initially was the same, and then the placebo group does better, and the treated group does worse. More death in the treated group. Well, maybe is again subgroup. Here there was patient at risk class 0, 1, and 2, 3 and 4, where they expected the most, is going the other direction. And why is that? is not cardiovascular death. There is a reduction in cardiogenic shock or CHF. Is really all non-cardiovascular deaths. And by looking at what happened, there were more sepsis or infection, significantly more sepsis of infection. Does it make any sense? How can sepsis or infection be linked to use of beta blockers? Yes. You were saying? Yes, so something that is not caused by the treatment may be masked by the treatment, picked up later, and cause death, which is exactly what they think happened. So if you read the abstract and in particular the detail of the result, they make that hypothesis. And they went on measuring secondary outcomes, and in particular was stroke. Because you're right, sepsis, but why patient in this class should have sepsis? Well, you know, it's surgery, there can be infective complication, they are masked, and it comes to late diagnosis of sepsis, not treatable, and death. Indeed, they discovered that was mediated by stroke. And most of the sepsis were secondary to ab ingestis pneumonia. So that was one of the mechanisms. This would have not been picked if not in a large pragmatic trial with careful look at all the outcome. The composite was in favor and was reasonable. Stroke was one of those, but was not analyzed independently. They went back to look at these after they saw the increase in mortality and the increase in sepsis. Now, this is the plot for stroke, so it's not only mortality, but even stroke goes definitely worse in the treated group. So if we try to make a global assessment, we say, okay, for non-fatal myocardial infarction, we have a positive effect. Is not big, but is significant. So if we start filling a profile, myocardial infarction, 10,000 patients, very well done study, high quality, 70% reduction, and these are the absolute risk reduction. Then we move to mortality. Mortality goes the other way. And again, there are no serious limitation. There is some imprecision, the confidence interval is wide, but this is the relative risk reduction, these are the absolute numbers. And then we can add stroke. In this case, this is the estimate, and you may say 10,000 patients again, very well done study, high confidence in result, and this is the increase, 2.2 times higher rate of stroke. What would you recommend here? For or against using beta blockers, and strong or weak recommendation? Against using beta blockers, and against using in everyone, or a weak? Weak means conditional. You may use it in some, not in everyone. What you would think would be the recommendation here? Weak, or even so strong, against beta blocker, with some exception. You may have patient where you have very low risk of stroke, and you may want to get some of the positive effect on cardiac function and coronary syndromes. But in general, the strong effect of beta blockers that was shown in 112 patient with a trial stopped early was not confirmed when assessed in 10,000 patients. Actually, beta blockers were shown to be causing harm. There are tons of examples like this. So staying in the surgical field, extra to intracranial bypass, initial case series showed benefit, and then instead, once an RCT was done, there was an increased incidence of stroke. The most common, the most well-known case in history, hormonal replacement therapy for menopausal women. Meta-analysis of cohort studies, risk reduction of 0.5%. There was a healthy user effect, and indeed, you have an increased risk of myocardial events when you use hormonal replacement therapy, and that was shown in a very large RCT. But a huge meta-analysis of observational trials was showing benefit. And the reason was that only women without cardiovascular risk factor were taking the hormonal treatment. Those at risk, they had already events, they were not taking the pill. But if you randomize everyone and you create two groups with the same prognostic profile, then the treatment per se increases the risk. Vitamin E, cohort study showing decreasing cardiovascular death, instead no effect in a randomized trial and so on. And the main reason is that usually the patient in cohort studies are worse at study entry, and so they may get more benefit for the few at the more at very high risk, but it's difficult to assess the effect of the treatment like in RCTs. So this Cochrane review showed, comparing observational studies and RCTs, that the population are usually different and differently distributed in the two treatment arms. So what seems initially something, when you look at it more closely, is something different. This is the advertising of a Don Quixote representation in Vancouver. And what are your take-home messages? Beware of trials stopped early, no matter where they are published. Expert can be as biased as pharma stockholders. Composite endpoint, physiology, the case of beta blockers, not always what you expect to happen in life, and observational studies may be confounded. You know to the nausea, but if you think of your own practice, there are a lot of medical intervention that are only based on observational evidence. And it may be challenging balancing risk and benefit in making decisions in clinical practice or in study interpretation. Any final question? If not, I'll thank you, and you'll move to the work group for systematic reviews, right, Fad? Yes. So time for a coffee, a snack, or stretching in 5 maximum 10 minutes. 5 to 10 minutes. We have to start the working group in the color room, where you know you will be spending some more of your time. Thank you.